Good evening, everybody. Today's class is on anterior segment imaging in glaucoma. I, Dr. Bhavini Johri, will be presenting, and Dr. MB Sir is the moderator for today. Introduction. So, anterior segment assessment is a critical step in the diagnosis of glaucoma, especially angle closure variants. The disease burden of angle closure glaucoma around the world is as shown in this table below. In Asian populations, it's around 0.3 to 2.7%. These are the details of various population-based studies carried around in India. In the Chennai glaucoma study, in the rural areas, we found a prevalence of 6.27% for primary angle closure suspects. Primary angle closure was 0.71%, and glaucoma was 0.87%. So anterior segment assessment can be done by clinical evaluation or by imaging. Imaging is an objective method of visualizing the anterior segment angle. The clinical evaluation can be done by torchlight, slit lamp, or gonioscopy. For imaging, we have the UBM, anterior segment OCT, sheen plug imaging, the scanning peripheral anterior chamber depth analyzer, and recent advances include goniophotography, which include the iCam, goniopen, and the NGS automated gonioscope. So, a comparison between gonioscopy and newer imaging technology reveals that gonioscopy is subjective, while the newer imaging technology is an objective method of viewing the angle. The gonioscopy has poor reproducibility, and the newer imaging technology has fair reproducibility. The gonioscopy is semi quantitative, while in newer imaging technology, we can do quantitative analysis also, and it also provides us an additional insight into the mechanism of glaucoma. This table depicts the sensitivity and specificity values of the flashlight test and the Van Herrick's test, and we found out that they are poor predictors for occludable angles. So moving on to indications for anterior segment imaging, the absolute indications include corneal opacity, identification of tubes, cysts and tumors.
Bhavini, just a minute. Can you just show the previous slide? So can one of the fellows tell me how you will interpret this data? How we actually use this information almost day to day in day-to-day practice. Okay, you want me to ask somebody specifically? Or will you volunteer?
The negative predictive value of Van Herrick's test is high. So, in routine slit lamp clinical evaluation, if Van Herrick's grade is 3 or 4, we don't do a routine gonioscopy because it can rule out an occludable angle.
So, what is a negative predictive value?
Sir, it's the number of true negative from the whole test negative.
It's the possibility that if the test comes out to be negative, that it actually is so. In simple.
Okay. So basically, when you see a patient, you only know whether the test is positive or negative. So the negative predictive value tells you how likely that result is true. So this is the information that we use in order to make a decision on who we gonioscope. So a negative predictive value does not rule out angle closure, but you are willing to take the chance that you're 90% of the time you're not going to miss a narrow angle. Okay.
What is the caveat here? Again, one of the fellows. How will you take this particular data? You know, what is the catch here? Again, Merin, can you pass it on to the next person? You can see that the prevalence of occludable angles of 21.9%. So it depends on where you are doing this test. If you're going to do in a population more than 40 years of age, where the prevalence is around 6 to 7%, this may not be true. There it may be variable, okay? So in a clinic population, especially a glaucoma clinic population, you may end up seeing much more prevalence than this. And so you may be much more confident in looking at this data. This is probably from a general ophthalmology clinic when they were doing it. So in a routine clinic where more than 40% for 40 years of age, above 40 years of age, expected prevalence of an occludable angle could be this. This actually is very high prevalence, right? So you got to be careful about the prevalence because negative and positive predictive values are dependent on prevalence of the disease.
So this shows us the indications for anterior segment imaging. The absolute indications include any corneal opacity, identification of tubes, cysts and tumors, any lens pathology, trauma, malignant glaucoma, or ciliocoroidal effusion. The relative indications are to study the bleb morphology, plateau iris, laser PI, biometry, and congenital glaucoma. So moving on to our first imaging technique, ultrasound biomicroscopy. This was introduced in 1950 by Munt and Hughes, and Baum and Greenwood introduced the B-scan. The transducer material earlier which was used was lead zirconate, which produced 10 megahertz frequency. Then came the first practical UBM system, which has a high frequency of 50 to 100 megahertz, and the transducer material used now is polyvinylidene fluoride. The features are that this has a high frequency ultrasound, which helps in getting a higher axial resolution and lateral resolution, but at the compromise of the tissue penetration depth, which is lesser compared to a USGB scan. The advantage is that images can be captured even through opaque media since we are using sound waves. We will be generating two-dimensional grayscale images of all the anterior segment structures. And one more advantage is that quantitative and qualitative evaluation both are possible. So the principle of this technique is that there's a high frequency probe which produces ultrasonic waves. These waves travel through a medium, which could be saline, and reach the intraocular structures. Then the reflected signal is converted back to electrical energy and amplified, and it is transferred to a high-speed scan converter, which produces an image, and we get that on our computer screen. So the patient position should be supine, topical anesthesia is applied, and with the help of an eye cup, we create a small water bath which contains our medium, which can be methyl cellulose solution or saline. This acts as our coupling medium. In this, we will place the transducer probe approximately 2 mm from the eye surface, and the reflected signal is best detected when the transducer is oriented perpendicularly. And one thing that we have to keep in mind is that we should not apply too much pressure on the eye cup, as that can distort the angle structures. This is an image of the eye cup and the transducer probe used. This image demonstrates how we are performing ultrasound biomicroscopy. The transducer probe is placed in the eye cup.
How many of you have seen an UBM being done? Or how many of you have done it actually? What is the frequency of the probe that we are using? You have a 35, 50, 100 different frequencies, right? Actually, 35 and 50 is what we use usually. But what is that we routinely use? Actually, it's a 35 megahertz. Okay, then only you can get both the angle-to-angle pictures. Huh? And can you do it in sitting position?
We can, sir.
So you can actually, you can have a cup holder, which is actually filled with saline, and you can use it to make the patient sit and do it actually. But the clarity is not that good. That's why we are continuing to do the supine position.
So these are the different types of ultrasound biomicroscopy scans that we can get: an axial scan, longitudinal scan, and a transverse scan. These are two sample reports. Moving on to anterior segment OCT. So this came in 1994, and
Can you describe it? What are all the images that you're seeing there? You can describe what are the type of scans there at least. Can you describe what are all the different types of scans that you're seeing there? Start. Just say something. It's okay to be wrong.
Axial scan.
Axial scan. What is the next one? Okay, go to the one below. It's okay. Lower left. Just now you showed, right? So this is a longitudinal scan, which picks the angle alone. Next. That says transverse scan. Okay, these things are, routine. These are all like not even ophthalmology. General ultrasound itself. Okay, so with the transverse scan, you can pick up the ciliary body image and the pars plana image. Okay, can you describe them quickly?
yes, sir.
This is more important than
The first picture on the left is an axial scan.
you have a mouse there. Yes, pointer.
Yes, this is the axial scan. This one is the longitudinal scan, and this is the transverse scan. This is longitudinal scan.
Go ahead. Go ahead.
Then this one is also an axial scan. This one is the longitudinal scan, and this is the transverse scan and longitudinal scan.
Make sure, I think it's not the patient's name, right? Optometrist.
Yeah.
Make sure when you're putting reports from patients, remove patient's name and MRD number, okay?
Next slide, sir.
Continue.
Yeah. So moving on to anterior segment OCT, this came around in 1994, and initially the same wavelength of light was used as retinal OCT. This wavelength is good for imaging the angle because there is limited scattering by the scleral tissue because of limited penetration. Then later on, the longer wavelength came, which has the advantage of better penetration through the sclera, and also we get real-time imaging. So the features are it's a non-contact rapid in vivo imaging process, and recently more improvements in technology have increased the speed and resolution of the images captured. The OCT image processing software allows us to combine multiple scans, perform three-dimensional reconstruction, and get accurate measurements. This helps us in preoperative diagnosis, intraoperative surgical decisions, and postoperative disease monitoring. There are various types available, time domain OCT and Fourier domain OCT. The Fourier domain OCT is further classified based on wavelength into spectral domain and swept source OCT. So the ASOCT is based on the principle of low coherence interferometry. So basically different structures in the eye have different refractive index. So when light falls on the different interfaces, it is backscattered, and then we will measure the echo time delay of this backscattered light to generate 2 or 3 dimensional tomographic images. In the time domain OCT, the reference mirror is also moved. In the spectrometer based and swept source OCT, the difference is that the reference mirror is kept fixed. This is a comparison between the different types of ASOCT. So as I mentioned, in the time domain, we will be moving the reference mirror, and in spectral domain and swept source, the position of the mirror will be fixed, which helps us to get more A scans per second. The spectral domain will give us 20,000 to 40,000 A scans per second, and the swept source will give us 100,000 to 400,000 A scans per second.
Can you go back?
Yes, sir.
So you have to look at the horizontal scan width, okay? Swept source has a 16 millimeter scan, so you can actually have an angle to angle scan. So if you want to get the idea about whether it is angle closure or not using an anti-segment OCT, you should prefer something which has a longer horizontal scan width. Spectral domain usually is not used very often because it only takes a very small area, okay? So you should know about all these things to choose what imaging can be used, okay? But generally we use UBM. Can one of the second years say why we use UBM most of the time for imaging?
Sir, because in ASOCT, the rays are not penetrating posterior to the iris,
Why? It's theory. Sorry, I can't hear you. Use the mic. Refractive index, is that correct?
And the depth of penetration because of the this frequency interferometry.
Yeah, with the swept source OCT,
No,
the depth of penetration is better. Actually, you have not mentioned the depth, is it? It comes in the next table. Why do you use UBM instead of ASOCT? It is infrared light, right? So what happens with light in the eye? Where it gets attenuated? Anyone from the PGs? Basic stuff, okay? So these are things which you should come with answers just like that. The infrared light, it gets absorbed by the pigment layer of the iris, right? So you don't see beyond that. Even the angle you may not see very well because of the crowded nature and also the attenuation due to the presence of limbal area there, sclera and other interfaces. So that's why we use UBM, which is ultrasound, which can penetrate through the layers. You can see the lens iris diaphragm better. So if you want to image the CB Fairy process and the lens zonules, you should prefer UBM. So it gives you better information, right?
So this table shows us the various commercial ASOCT devices available and the different axial resolutions, the scanning speed that we can get, and the depth into width we can get.
Cirrus OCT, not citrus.
This is an ASOCT image of the time domain OCT showing open anterior chamber angles.
Can one of the second years interpret this?
This is an hello. This
Yeah.
is an axial time domain OCT scan of the eye, in which we can see that the corneal anatomy is within normal limits, and we can see the angle structures. It appears to be of normal depth.
That's all?
The
So-
iris can be seen and
No, you have to tell what is it, open or closed angle.
Open
Do you see
angle.
the lens? Okay, so you have to describe the entire frame. What are all the structures you are seeing, whether the scan is of good quality or not. First of all, this is not a very good quality image, okay, because you need to be very well centered. The light should go perpendicularly. You should see a central line, a perpendicular line across the cornea. Then only it is well centered. You should also have a good high reflective image at the angle. So then only it is the light, has penetrated it properly or perpendicularly. Okay. Of course, in this axial image, it may not be very well seen, but if you put the central line comes, then you will usually see a enhanced image quality at the trabecular meshwork area. You should be able to see the scleral spur as a single point also. So that then only it's a very good quality image, and you should see the entire anterior curvature of the lens. Okay. So that is a good quality centered image of the anterior segment OCT. This is not a very good image. Keep
so we
going.
cannot see the anterior lens curvature because it's a time domain scan, or because the scan is not done
Not
properly?
centered.
It's not centered.
Or probably this image, you can see it, but it is very faint. You can describe it.
So this is a spectral domain OCT showing a normal anterior chamber width. The anterior chamber angle is open. Anterior lens surface is seen.
So it's an open angle.
Open
So again, you can see the quality of the image at the angle gets attenuated because of light absorption. Okay, this is a 14 to 15 millimeter scan, but the angle structures are not fully visible, but you can more or less make out it's an open angle. Okay.
This image is an image of angle to angle spectral domain OCT.
Can you go back? You should be able to understand which manufacturer also. This is a Cirrus image. Okay, Cirrus OCT image. The previous one was a time domain OCT, Visante OCT. Okay, so you should know. Unless you really go and look at the images, you should not be able, you will not be able to. Okay, go next one. Anybody can say which machine is this is from? Go ahead, you tell.
So this is Cirrus OCT.
Oh, Cirrus. Okay, put it. Sorry, I didn't see that. Okay, continue.
This is also Cirrus OCT spectral domain showing the angle structures in high definition.
Can you point
Yes.
out the structures? The whole point is for you guys to understand the image and what structures you are seeing. Otherwise, there's no point. Okay.
Yes.
So I want you to interpret.
So this U-shaped interface that we are seeing is the transition between cornea and sclera. And at the end of this U-shaped interface is the Schwalbe's line. And this bump that we are seeing as an invert projection into the anterior chamber is the scleral spur. This is the angle recess area showing an open anterior chamber angle. This is the anterior surface of the iris. And structures posterior to that are not very clear.
Okay. What you're seeing as a slightly higher reflectance between the Schwab's line and the scleral spur on the scleral side is the trabecular meshwork. Usually, if you will be seeing it as a triangular structure. Okay. And sometimes, if you're lucky enough, you may be able to get a Schlem's canal there also with this kind of resolution. Next.
So this is the ASOCT machine. The patient's head is placed on the chin rest, and then
These are practical stuff. Keep going. These you guys should go and learn yourself. Huh? Keep going.
This table shows us a comparison between UBM and ASOCT. The UBM is based on ultrasound and ASOCT is based on optical technology. In the ASOCT, we get a wider scan, 16 into 6 millimeters, while in the UBM, there's a limited field of view of 5 into 5 millimeter. For UBM, we need an operator, but in ASOCT, there's no need of an operator. And also in ASOCT, we do not need any contact. There's no need of an immersion bath, but we are unable to visualize structures posterior to the iris and if there's a corneal opacity. Quantitative and real-time imaging is possible in both. And in UBM, we prefer supine position. In ASOCT, upright position. UBM gives us a smaller field of view and ASOCT provides us a wider field of view.
Can I go back to that picture?
Yes.
Yeah. So this, I want you guys to pay good attention to. This gives a proper properly taken image, you can see the line across the cornea, so it is centered properly. And you also see some high reflectance at the angle. It's an open angle, what you're seeing. And that's the interface, what you're seeing, that U-shaped solid line. What happened? Yeah, so that is a position where you have the Schwabi's line, that is the beginning of it, and the posterior cross mark is the scleral spur. These are all very approximate, but usually if you see a dotted spot there, that is the scleral spur. Okay, beyond that you may not be able to visualize much. So up to this structures, if you can know, then you can interpret open or closed angle. The whole idea of looking at the structures is to see if it is open or closed.
For quantitative analysis, there are various parameters that are used, such as angle opening distance, angle recess area, trabecular space area. This is a table showing us all the quantitative parameters used. Lens vault is the perpendicular distance between the anterior pole of the crystalline lens and line joining the two scleral spurs. This picture shows us all the quantitative parameters that are used. This is the iris thickness, 1, 2, and 3. This iris thickness is measured the perpendicular distance between the anterior surface of the iris.
No details. It's okay. Quantitative parameters are not that important, except angle opening distance.
Okay. So this UBM image is showing us the measurements of the iris thickness. This UBM image is showing us the lens vault measurement. So there's a perpendicular line joined from each of the scleral spurs, and then the perpendicular distance between the anterior pole of the crystalline lens and the line joining the two scleral spurs is taken as the lens vault. This is an
Go back. So one of the fellows, what do you see in the first image, and what do you see in the second image? Vis-a-vis the lens vault. The first image was not marked very correctly, but I think it was approximately done. They have not put the proper scleral spur marking. But it doesn't matter. You can just forget about that line there. What do you see?
First image, the lens vault is lesser, and second one, there is increased lens vault.
High lens vault. Okay. So what is happening there? Is it? So what is the angle picture compared to the lens vault?
Narrower in the second.
Narrower in the second one. So it's a generally speaking, if you have a high lens vault, there is a possibility of a angle closure, but then it is not always the case. Okay. So just don't go by the lens vault alone. Next.
This is an image of ASOCT quantitative analysis in open angle, which is showing the angle opening distance, angle recess area, and other quantitative parameters. This is the quantitative analysis done in closed angle. This image is showing us the HD angle measurements for Cirrus OCT machine. As Sir had mentioned, the angle opening distance is important. So the angle opening distance is taken from a point 500 or 750 microns anterior to the scleral spur. And it is the triangular area which is bounded by the corneo-scleral interface, the anterior portion of the iris, and the apex of the triangle here. So the first image here is an ASOCT scan, which is showing us open angles. And this is a UBM picture showing us open angles, and ASOCT here, this also shows open angles.
That's not ASOCT, that's UBM.
UBM, sorry. Yeah, UBM image showing us open angles. In this image also, we can see open angles are present.
And that's pseudophakic.
Yeah, pseudophakic.
You have to get as much information from the imaging, okay? So quickly summarize that.
This image is showing us a comparison between ASOCT done in dim versus bright light. So in dim conditions, we can see that the iris surface is opposed to the trabecular meshwork here, showing us appositional closure. While in light conditions, we can visualize the angles are getting opened.
Okay, one of the fellows. So what happens when the pupil dilates to the iris? Iris volume increases. So why? What is the theory behind that?
Because iris.
Why does it not happen in open angles? Not that much. Okay, so closed angles tend to have a higher lens volume in it, and that is one of the reasons it acts like a sponge in nature, and the fluid is not let out of the iris. So that tends to bunch up in the periphery and cause closed angle. So that is one of the theories put forward. Okay, so that's something which you should know: iris volume. What happens to it in closed angles? Next, that's what you're seeing with the dim light and bright light here. Next.
In this image, we can see dim versus bright light, synechial closure on ASOCT. Here.
Can you say synechial closure on ASOCT? Can you confirm it? No.
No, sir.
You should do it on gonioscopy.
Gonioscopy.
All right. This is just which is confirmed on gonioscopy, just putting it for the picture. So make sure that you do a proper gonioscopic diagnosis. Next.
Then this is a UBM image showing us closed angles. As we can see, there is pupillary bowing here, and the angle is not visible. Here we can see the iris is bowed and anterior lens surface is visible.
One of the second years, what is the mechanism here of angle closure? So if it's a primary condition, what do you call that? Relative pupillary block. You should use the correct terminology. Next.
This is the ASOCT image showing us closed angles because of pupillary bowing. And in this picture also, we can see that the angles are closed and the lens vault is increased.
Not much of the relative pupillary block. This is more of an oppositional angle with the lens volume being more. You have a high lens vault. That's what you see with lens induced mechanism. Okay. What you should be careful about in these kind of cases? You're seeing something like this. Yeah.
Ecomorphic glaucoma.
Okay, that is good. What else would you be thinking of? You're correct. So you should think about secondary causes of lens induced angle closure, right? So you should think about a subluxed lens or a phacomorphic type of lens. Okay.
Then these two images show us the angle closure present before doing a PI, and after doing PI, there is flattening of the iris, and the angles have opened up. Then moving on to plateau iris configuration. In this, we can see
one of the fellows. I think you already put it up on the side. It's okay. Go ahead. Continue. It's fine.
Yes. So we can see that the ciliary processes are anteriorly positioned. The ciliary sulcus is not visible.
You are showing somewhere else.
Sorry.
Show it properly.
Yeah. The ciliary processes are rotated anteriorly, and the ciliary sulcus is not visible. The angle is obstructed by the plateau iris configuration. Then in this image, we can see PCIOL is present and it is rubbing against the posterior surface of the iris, leading to secondary pigment dispersion.
Just one comment here. You will see this rubbing on the PCIL, rubbing everywhere, written in our reports. But don't forget that rubbing is a dynamic process. On a report, you can only say that it's in contact.
Okay, sir.
When you're doing the UBM and you're actually seeing the iris moving, that's okay. Be careful when you make the statement rubbing based on a static image.
Okay, sir.
Can you go back before one slide before? Okay. Second years again. How will you make a diagnosis of plateau virus? I'm asking overall, not just imaging. There is plateau virus syndrome, right? IOP spike after patent PI and on dilation, right? So I'm asking about how will you find a plateau iris configuration? So UBM is good to confirm such conditions, but your diagnosis is mostly clinical. Okay, so remember that.
Ciliary processes.
Where do you see the anterior positioning of ciliary process? So usually the ciliary process should be directed more posteriorly. So here it is almost in parallel to the iris. So that is how you should identify it as anterior positioning. Okay. Absence of ciliary sulcus. Yeah, third point, where is the iris root indentation
Yeah.
caused by the ciliary body? It's not a very good image for that, but usually you will see that the peripheral iris is pushed by the ciliary process. Okay. And of course, a closed angle. All these are important.
So these are the UBM pictures of pigment dispersion syndrome, where we can see the angle is open and the iris is concave posteriorly in both these images. The anterior lens surface is visible. These are
Go
two.
back.
Yes.
What else would be the hallmark of pigment dispersion? You will be seeing the
Uh,
iridozonular contact.
yes.
Okay, so that is where the pathology of dispersion is seen. It is not a very good image, but I'm not
Yes,
sure if
sir.
it is. On the right side, you can see the zonules also, but I'm not sure if it is in contact. But with that much of convexity, again, it is a dynamic process. So when they are doing the UBM, they will be able to see that it is touching. Okay, so that is one of the important pathologic mechanism. So if you see an iridozonular contact, in those days, the people used to do a PI to decrease the concavity. It may work in favor of stabilizing the IOP and decreasing the pigment dispersion. It's only a theoretical possibility. Next.
So in this first image, we can see that there is zonular loss. And in this picture, we can see the zonules are still intact, secondary to trauma.
Okay, keep moving. You got to finish. You have more slides, I think.
Yes, sir. So this first image is showing a detachment of the ciliary bodies present from the sclera. So this is a cyclodialysis cleft. In this image, we can see angle recession is present. The ciliary body face is visible. This is a UBM image showing we can see the anterior lens surface, and we can see that it is subluxated.
The way in which to identify the subluxed lens, subtle signs are you will get a coiring of the edge of the lens, okay, because the zonules are not attached to it, and you will see that change from a rounded edge, it will become a squarish edge, okay, and also you will see actual absence of zonules. Again, it is a dynamic thing, so just from the plates you may not be able to identify exactly. That is why you guys have to go and watch UBM being done.
So moving on to malignant glaucoma. So this UBM image shows that the central AC is shallow. In addition, and also there is peripheral shallowing, and the lens has been pushed forwards, and ciliary body is anteriorly rotated. So this is an ASOCT of showing malignant glaucoma in a phakic eye. And here we can see the anterior lens surface is a pseudophakic patient showing malignant glaucoma. Anterior chamber is shallow. So this first image shows us, this is a UBM image. We can see an hyporeflective area showing the iris cyst, which is causing angle closure. This is the iris cyst. And on UBM also we can appreciate here the iris cyst is present. This is an ASOCT spectral domain image showing the iris cyst pushing the iris against the trabecular meshwork. These two are UBM images showing ciliary body cysts. In here, this hyporeflective area shows us a single ciliary body cyst. And here we can see multiple hyporeflective areas showing multiple ciliary body cysts. So on this slit lamp photo, we can see there's a mass lesion involving the ciliary body. So we have taken a UBM of that, and this lesion here involving the ciliary body that is causing the iris to be pushed forwards against the trabecular meshwork, causing closed angles.
This is probably the most important thing when you are seeing an iris cyst-like picture on slit lamp photograph, to do an UBM and make sure that it is not a malignant lesion. It's a rare condition, but you should get a UBM done when you're seeing some image like this.
So one use of anterior segment OCT is to see the bleb after trabeculectomy. So here we can see one hyporeflective area, which is our bleb. Here, this is the formation of a tenon cyst. And here we see a flat bleb. This is a non-functional bleb. And, these two images show us a high functional bleb. This is a serous OCT image showing us a cystic bleb. So this is an ASOCT image showing us a patent AGV tube in C2, and a UBM picture showing us the UBM that the UBM tube is patent. Then coming over to a UBM image of
Again, when you're
microspherometry.
getting an AGV implant, it is like a dynamic thing that is more important, whether the tube is touching the corneal endothelium or not. In the second image, you saw some changes in the corneal endothelium. It is possible that it is touching the corneal endothelium. So you got to watch that eye. So it is again dynamic process. You need to check that part. Okay. You should ask the technician to say what is there. Is it touching the corneal endothelium or not? They should be able to dynamically check that. Next.
So in this UBM image, we can see that the anterior posterior thickness of the lens is increased and equatorial diameter is less. These are UBM images of nanophthalmos.
For non-ophthalmos, UBM is not necessary for diagnosis. You need to know what is the axial length. There are axial length cutoffs. So in this, it is just an imaging done to find out lens thickness. Okay.
You also have an ultrasound picture there.
Yeah. Can you
Not
show
just the UVM.
Yes.
what is the axial length there?
16.97.
Yeah.
So in this UBM image, we can see there is ciliocoroidal effusion here. So moving on to recent advances. So we have the scanning sheen plug imaging, the scanning peripheral anterior chamber depth analyzer, and goniophotography. In the goniophotography, the prototypes which are available are GonioPen and Axicon lens-assisted gonioscopy, and commercially available ones are iCam and NGS1 automated gonioscope. The scanning sheen plug imaging is based on the sheen plug principle. So usually if the object and the film plane is kept parallel, we get an image of higher resolution. But for scanning sheen plug imaging, we will be orienting the object and the film plane in such a way that there is an intersection at the sheen plug point where we can get the maximum resolution. This is an image of the scanning sheen plug imaging. It is a non-contact optical system, and all the AC parameters will be quantified to create three-dimensional images. We can get 50 slit images of anterior segment taken in less than 2 seconds. So moving on to SPAC, this is a non-contact system, and it measures the anterior chamber depth. We will be taking 3 measurements, and the mean of the anterior chamber depth values at each point is measured. They are converted to numerical values, and we can also assign grades for the risk of angle closure. So this shows us the SPAC system, and the patient will be gazing into a fixation lamp, and this is the at a 60 degrees angle, the light will be shined into the patient's eye. And then there's a charge coupled diode camera attached, which will be connected to the PC, and then we can get images on the monitor. Moving on to iCam. So the iCam provides us high resolution color images of the anterior chamber angle, and we can get 123 degrees and 130 degrees wide field lenses. The advantage is that it is portable and handheld, and disadvantage is that it's costly. We cannot perform indentation, and we cannot visualize the corneal wedge, or if there is light pigmented trabecular meshwork, we will not be able to visualize that. So these two images show us, this images shows the inferior quadrant showing a closed angle, and here we can see an open angle. The NGS automated gonioscope captures circumferential 360 degrees gonioscopic images, but the disadvantage is that indentation gonioscopy is not possible. And the 2D images which will be taken, they do not provide us enough depth of view for grading. This image shows us a GonioPen, which combines high resolution miniaturized integrated charge coupled diode camera and light emitting diode light source based probe system. And we can evaluate the iridocorneal region inside the eye. When we place it near this limbal region, we can evaluate the opposite iridocorneal angle. In Axicon lens assisted gonioscopy, this is an attempt to improve the gonioscope image resolution, but still there are some challenges remaining, such as lighting control, the magnification adjustments, and expertise requirement. Then moving on to the disadvantages of all these recent goniophotographic systems. So they provide us limited resolution of the trabecular meshwork, and also several images are required to select the best one. And NGS1 has this advantage that it can do this selection semi-automatically, and we need to interpret these images. So the future lies in the development of artificial intelligence. In this, we will have an automated system and that can identify angle closure without depending on scleral spur localization. And there are techniques such as deep learning techniques which will help us get automated processing done, and large data sets can also be processed and we can identify new disease patterns earlier. This image shows us a deep learning method in which the ASOCT image is processed through convolutional neural layers. They will extract all the deep features and then we can classify the angle as angle closure or open angle. So in conclusion, anterior segment imaging plays an important role in angle assessment. It is rapid, non-invasive and in vivo along with quantitative measurements, but the availability, cost and interpretation remains a challenge. So we should use it always to complement gonioscopy, but we cannot replace it with gonioscopy. These are my references. Thank you.
Okay, good work. All of you should know how to interpret ASOCT UBM images, should be able to describe, and you should at least have tried at least once or twice hands-on under the supervision of someone. Okay, I want at least the fellows to do that. Okay, if you have not done it before, please go and try your hands-on under supervision of someone. Don't go and injure the patient's eye. Then you will know how the system works. At least you should know how to interpret the images properly. Okay, right.
And I think you showed a picture, but you should also be familiar with how to interpret the Cassia image, the 360-degree circumferential scan. I think you showed a picture somewhere. I'm not because the automated scan. We should at least know what it tells you and what its relevance is, because in some ways, a lot of serial imaging is going that way. And I don't think you have a picture here.
No.
Maybe that's something that all of you should update yourself on. But as Bhaskar said, there is no substitute for a good gonioscopy. So it's more important that you spend time learning gonioscopy. You do definitely need to know about this, but gonioscopy is what is going to be your in-pocket imaging system. Any questions, any comments from anybody?
Okay. Thank you.
Thank you, sir.